Hello, this is Kimberly Kearns. Today we'll be discussing irritable bowel syndrome. In this module, we'll do a quick overview on diagnosis, clinical features, and a very brief overview of medical management of irritable bowel syndrome. Let's start with the definition of irritable bowel syndrome. IBS is a chronic gastrointestinal condition that may be characterized by abdominal pain, bloating, distension, flatulence, and bowel disturbances. Irritable bowel syndrome affects an estimated 35 million people in the United States. There is a worldwide prevalence of 11.2%. When we look at data, it is very startling to recognize that over 75% of patients who actually report symptoms similar of IBS actually remain undiagnosed. So why start with the module on irritable bowel syndrome? Well, irritable bowel syndrome is the most common clinical diagnosis in gastroenterology. And for those of us, of course, we're advanced practice providers in gastroenterology, this is a condition that we are going to see very regularly. 30% of all referrals to gastroenterologists are related to IBS. It is the 7th most common diagnosis by primary care providers. And we know that a lot of our primary care team reaches out to us specifically about management of IBS patients. IBS is also the second highest cause of work absenteeism. There are also multiple studies that look at the effect of quality of life when it comes to IBS, and health-related quality of life scores are lower than that of patients with diabetes, hypertension, and end-stage renal disease. IBS also has a significant cost on healthcare with direct and indirect costs up to $30 billion. So let's talk a little bit about the diagnosis of irritable bowel syndrome. So Rome-4 was first published in 2016, and we use Rome-4 because it helps us in creating a kind of classification in defining irritable bowel syndrome, as most of the symptoms that define irritable bowel syndrome are subjective and self-reported. So we now have a tool to help us with making the diagnosis. So let's review Rome-4 criteria for IBS. So our patients must have recurrent abdominal pain at least one day out of the week in the last 3 months associated with 2 or more of the following criteria: related to defecation, associated with a change in stool frequency, or associated with a change in the stool form or appearance. This criteria must be fulfilled for the last 3 months with onset of symptoms 6 months prior to diagnosis. As we just mentioned, part of the criteria for irritable bowel syndrome is a change in stool form. I will tell you the Bristol Stool Form Scale is essential when trying to make this diagnosis. As an advanced practice provider in gastroenterology, I will tell you that this tool has become essential in my clinical practice. I actually keep a copy of it in my pocket, and on clinic days, there are copies in each and every exam room. As a clinician, I will tell you that this will help you quantify during your documentation, and also will assist with a visual tool to assist your patient in describing their stool form. It is very difficult for patients to verbally explain their stool form, and if you're able to give them a visual and then state, can you please point to the stool picture that is closest to the stool form that you are currently having, it is of great assistance. Now we know that IBS is classified into 4 subtypes. We have IBS-C, which is traditional type 1, type 2 on the Bristol Stool Scale. We have IBS-D, which again correlates with Bristol Stool type 6 and 7. We have IBS mixed, which of course provides a variety of stools between type 1 and type 7. And we also have IBS-U, which is IBS undefined. And believe it or not, that means that they do not fall into any of the categories that we currently have between IBS-D, IBS-C, or IBS-M. The pathophysiology of irritable bowel syndrome is very complex and not completely understood. But as an advanced practice provider, we must be able to explain to our patients the underlying pathophysiology of any condition when we're going about diagnosis. And let's take a few minutes to review some of the underlying etiologies, the pathophysiology of irritable bowel syndrome. As we know, IBS is classified as a functional GI disorder, so unlike organic bowel disorders, a diagnosis of IBS is based primarily on the presence of particular clinical symptoms in the absence of any kind of anatomical abnormalities. So again, let's start with, of course, GI motility. All of us, this makes sense to us, right? If there's an increase in frequency or irregularity of luminal contents, so a quick motion, right, that would be, of course, IBS-D. There's also could be an exacerbated response to cholecystokinin, so after meal ingestion, and this can also cause IBS-D. But if there's prolonged transit time, then of course think IBS-C. So the next thing we talk about is genetic issues. So there's lots of data currently evaluating if there is a genetic predisposition to IBS. As you saw in some of the first slides, there's a 2-to-1 female predominance in this condition, but also is there an association with serotonin transporter gene deficiencies? So could there be any issues with that? And I think that that's still something that is up to debate, and we're still doing a little bit of research on it. And I know everybody always says, well, my mom has irritable bowel syndrome, does that mean I could? Well, we can't say the answer is no, because there may be some genetic predisposition as well. We know that psychosocial factors and stress definitely attributes to symptoms of IBS. Anxiety, psychosocial diseases like depression or phobias, and something important to address is even coping skills. If a patient doesn't have great coping skills, we know that this can definitely exacerbate their symptoms of IBS. We know that these psychological factors alter GI motility, visceral hypersensitivity, which we'll talk about in a few minutes, and also disrupt the brain-gut axis. And this is a perfect kind of segue to then move into discussing the brain-gut axis. So signals from the GI tract influence the brain and can cause a change in motility, secretion, and immune function. It's well known that the nerve systems from the brain and the CNS follow the vagus nerve. There's a bidirectional communication which is made possible by the neuronal pathway, which is commonly known as the brain-gut axis. This may provide some insight as to how digestive processes may influence brain chemistry. So if we're a little bit unhappy, sometimes I know I eat a little bit of chocolate and that tends to kind of increase our mood sensation, right? So maybe is there something about what we're eating digestively then triggering our brain? But also in reverse, how behavior may affect gut chemistry. And I think the greatest example of this would be right before you're about to give a big presentation and you have an actual sensation of feeling nauseous or even having an increased motility of your gut. So again, that's that brain-gut correlation. And the role of serotonin, or 5-HT, is also associated with the functions of 5-HT on the central nervous system. But it's very interesting that 95% of this molecule is actually located in the gut. So again, signals from the gut tract influence the brain and can cause changes in motility, secretion, and immune function. We'll spend a few more minutes talking about the gut microbiome on the next slide. Let's move on to diet. We know that the diet is actually the #1 thing that can alter the microbiome, but we do know that diet can increase intestinal permeability and also cause immune activation. So there are specific food antibodies that can cause this. If a patient has carbohydrate malabsorption, if they're ingesting sorbitol, or even if they have fructose intolerance or gluten sensitivity. When we go to discuss immune activation, I think that is best also described under microbiome. So we're going to move on to, of course, visceral hypersensitivity, which initially this was kind of the mainframe when we talk about pain, because pain is the defining factor, right, in irritable bowel syndrome. So visceral hypersensitivity is a heightened sensitivity to the intestines to normal sensation triggered by the bowel distension or bloating. It's usually mediated by the GI nervous system, so again, that brain-gut axis, and of course central modulations from the brain, just as we were discussing before. Now, let's move in and talk a little bit further about the microbiome. Let's talk a little bit further about the microbiome. I know we mentioned earlier there's a multitude of factors that can cause irritable bowel syndrome. I think one of the newest and hottest topics in gastroenterology is the GI and the gut microbiome. So let's talk a little bit further about the underlying issues of what's called dysbiosis, or an alteration in the gut microbiome, and its effect on IBS. So we know when there's an imbalance of the gut microbiome, as you can see from the image here on the slide, that there can be an increase in bacteria, which can cause gas and fermentation. And just like we talked about before, that visceral hypersensitivity, we have an increased sensation of bowel distension, again, sometimes causing further pain or abdominal bloating. We know that there can definitely be an altered GI motility. There's a change in short-chain fatty acids, which can definitely increase GI motility. We know that alterations in the microbiome also stimulate serotonin, which we just talked about before, also works on motility of the gut. So altered microbiome or dysbiosis actually can cause an increase in GI permeability. And as you can see from the graphic, you can see that bacterial antigens then move through the mucosa into the submucosa, which then sets off almost like an immune activation, as you can see here by the graphic. So we know that there are several different mechanisms, even with an alteration in the microbiome, that all lead back to underlying symptoms related back to irritable bowel syndrome. And I just want to point out that effective and individualized management of IBS can be facilitated by enhanced understanding of the disease process. And that's why we have to review pathophysiology, so we understand the disease process. Now, let's talk about the evaluation of our IBS patients, because that's what we need to do best. All right, and I believe that we can do this based on 4 factors. 1, clinical history. Talk to your patient. Ask them questions about what they've tried before. Ask them about their symptoms. Do they fit the Rome criteria? So do they have a change in stool form, frequency? Is it related to abdominal pain? Remember, that's the key element behind that. So the next thing, of course, is physical examination. You must do a great physical examination. If a patient comes in with diarrhea, I will tell you that a rectal exam should be performed, because what if the patient actually has constipation and has overflow diarrhea? So, do a good physical examination. Make sure that there are no alarm features, which we're going to review a little bit later in this module. The next thing is limited laboratory testing. Remember, initially we talked about the high healthcare cost of a patient with IBS. A lot of this is related to the fact that there are so many tests that are being done for patients before they reach their diagnosis. So let's review how we can do these limited lab tests. I suggest a CBC, a CMP, a thyroid profile, celiac serologies, stool studies if they're diarrhea predominant, inflammatory markers, and a fecal calprotectin. Now, in colonoscopy only when clinically indicated. So these are our 4 factors: clinical history, physical exam, limited labs, and colonoscopy when indicated. Now, I'm very aware that IBS can mimic other conditions, which you can see up here, but if we do the limited lab tests as they are listed here on the slide, you can see with a CBC, we can exclude anemia. We're looking for metabolic diseases too when we look at a CMP or a TSH. Celiac serologies will help us determine if a patient has celiac disease or not. With stool studies, we're rolling out infectious etiologies, and even with our inflammatory markers, or now the newest test, a fecal calprotectin, we can pretty much tell if a patient has an underlying inflammatory issue going on as well. And I wish to point out there is no single diagnostic algorithm. There's no gold standard as to how to diagnose this. We have clinical tools, like we talked about, the Rome criteria, but no diagnostic algorithm. And I will tell you that utilizing this clinical evaluation, just as we discussed with the limited laboratory test, there's plenty of data that says if you follow this, along with making sure you exclude alarm features, you can accurately diagnose irritable bowel syndrome 90% of the time, actually greater than 90% of the time. So keep that in mind. Now, let's review alarm features, because we don't want to miss this. We want to make sure if we're going to diagnose irritable bowel syndrome that we do it right. So make sure there is no rectal bleeding or melena. Make sure there is no unexplained iron deficiency, anemia, or any type of anemia. If they have severe or progressively worsening symptoms, if their abdominal pain is out of proportion to exam or it's progressively getting worse, this needs further evaluation. If they have unexplained weight loss, if they're experiencing nocturnal diarrhea. This means if a patient is sound asleep and it wakes up in the middle of the night in order to have a bowel movement, this is nocturnal diarrhea. The next thing is incontinence. And incontinence meaning they have lack of control and not being able to hold their bowel. Not that the patient has urgency trying to get to the toilet, can't make it to the toilet. I'm talking about the first thing, which is where they have no control whatsoever their bowel. They're not even realizing that they're having a bowel movement. If a patient has a fever, if there's a family history of organic GI diseases, so if they've got a history of colon cancer, celiac disease, or IBD, they require further evaluation. And if they have a new onset of symptoms over the age of 50. Well, as we just talked about before, I know we said colonoscopy when clinically indicated, but if they're at the age of 50, now actually I think they've changed to 45, they should be having a colonoscopy anyways. So we make sure that if they have if they are new onset of symptoms and they're over the age of 50, they get a colonoscopy anyways. And again, usually when you're taking your history, patients will say, yeah, I've really had these symptoms for over 20 years now that I think about it. Pharmacological therapy should really be targeted toward your dominant symptom. This slide is more to be utilized for your reference. We're not going to go into pharmacological management of IBS. We're going to do that on a different module. But if their patient has primarily diarrhea predominance, here's a reference for you. Along with constipation, you can see here are some references of therapies for you as well. They have abdominal pain. Again, we have some listed references here, including antibiotics or antispasmodics, or bloating, again, probiotic or antibiotic. Now again, some things to remember is that patients who have IBS may have more than one symptom, so using one or more therapies from each of these categories may be needed. In many situations, a patient may want to try lifestyle modifications before pharmacological options for IBS. And even if they do wish to have a pharmacological option to treat their IBS, I always suggest lifestyle modifications as well. As we mentioned earlier, when we talk about the pathophysiology of irritable bowel syndrome, the number one thing that can alter your microbiome is diet. I always have patients start a diet library to really review what they're eating. I'm a big proponent of what you put in is what you're going to get out. But also we can suggest things like a low FODMAP diet or even a gluten-free diet. Structured exercise has been proven to improve abdominal pain and also symptoms of IBS, sleep improvement, and stress reduction. I talk to my patients a lot about diaphragmatic breathing as well, as we know this increases oxygen to all cells. It helps also to relieve muscle tension. So let's review some of the take-home points for irritable bowel syndrome. Assessment is key. Does your patient meet the Rome criteria that we discussed? Are there any alarm features that you're aware of? Now, I know we briefly reviewed some of the pharmacological management of IBS, but remember, target your treatment towards the individualized symptoms. If it's diarrhea predominant, use some therapies that are listed under the diarrhea column. And you may need to use a variety of treatments alone or in combination in order to manage their symptoms. IBS waxes and wanes, as I know over my clinical experience as well, so symptoms may change. Therapy may also need to change. Keep that in mind and inform your patient that that's an expectation that you have. Make sure to ask what treatments have already been trialed. If a patient has already been on multiple therapies, do not repeat them. What is the technical definition of insanity? I'm sure you know, right? Repeating the same thing over and over again and expecting a different outcome. Okay, let's gain our patients' trusts. Let's make sure that we listen to what they're saying and don't try and repeat a therapy that they've already failed on. Provide education and reassurance. IBS is not a life-threatening disease, but we know that our patients that have this have had significant decrease in quality of life scores, and we know that they've had this condition for a long duration of time. We need to provide them reassurance and education about their disease process, and also provide comfort that they know that we are going to help them. Prevent complications of IBS. Don't order unnecessary diagnostic procedures, surgeries, or a patient can even have adverse side effect because of medications. Utilize the criteria that we talked about in order to make your diagnosis of IBS. Also, as an advanced practice provider, we should try to reduce the impact of IBS, improve quality of life, and minimize global impact by reducing healthcare costs. I hope that this module has provided a little bit of a foundation for you in regards to IBS. And I just want to remind everyone, effective individualized management of IBS can be facilitated by enhanced understanding of the disease process and current clinical approaches to this disorder. Thank you.